Welcome back to Hardcore Connections. Today we're going to talk about medications for opioid use disorder. We have a special guest today, Dr. G, who is the medical director at High Point Treatment Center. Welcome. Thank you for joining us.
Thanks for having me.
I'd like to just start off and talk about kind of what a medical director role is in a methadone clinic.
So, methadone is a medication that's approved by the FDA for the treatment of opioid use disorder. And in that setting, an opioid treatment program is a highly regulated federal and state program. And so for methadone, in order to receive methadone through a clinic, it has to be through one of these special clinics. And the methadone clinic here in Plymouth has been in place for about 3 years for High Point, and it's not the first methadone clinic for the Plymouth area. For a standard intake, a patient is either referred to us by a treatment center, a detox facility, a hospital, family member. Methadone is well known to be useful for opioid use disorder, and so we don't have a cure for opioid use disorder. And methadone actually is the longest medication that's been available for this condition. It dates back to 1965 and initially studied back in 1930s. So generally, there's an intake process where the patient has to screen positive for opioid use disorder. The guidelines have changed to become much less restrictive over the past few years because of COVID. But in general, if somebody meets criteria for moderate to severe opioid use disorder, then we can offer them maintenance treatment in the form of either a protracted or prolonged detoxification or a chronic maintenance phase. We offer both because even though we don't have a cure for opioid use disorder, some patients choose not to want to stay on treatment forever, and so we try to respect that and honor their goals and meet them where they're at. But in general, if somebody meets the criteria and they're willing to understand and have what you call informed consent about the medication and the potential for issues that arise with other medications and or potentially harmful conditions. If the patient screens and they don't have any worrisome history or symptoms or medications that could interact with methadone, then we offer methadone as a daily dose.
Real quick, what are some medications that actually interact with methadone that may be positive or negative?
So methadone can prolong the cardiac conduction in our heart. And so any medication that has the potential for prolongation of the electrical conduction system in the heart can be made worse by adding another medication that could do the same thing. So the risk is a fatal arrhythmia. That's the typical thing that we are the most concerned about. And an arrhythmia would be a situation where your heart conduction doesn't support the heart as a mechanical pump, and that could lead to death. So we have to be very careful in selecting patients and trying to make sure that they understand that methadone can be potentially dangerous.
Yeah. Now, when a patient comes in, actually, how does that conversation look when they ask, okay, so how many milligrams am I going to be started? Like, how do you, as a medical doctor, how do you decide, like, the rate in which they're increased and how you know when they're at a comfortable level?
Sure. I think that the important thing is we offer, even if somebody shows up to a methadone clinic, they should be offered, there's 3 FDA-approved medications for the treatment of opioid use disorder. So even though they show up for methadone, I educate them on buprenorphine or Suboxone and naltrexone or Vivitrol. So those are the 3 FDA-approved medications for opioid use disorder. If they choose to be on methadone, the biggest determinant of the initial dose of methadone is their level of tolerance to the opioid. So if somebody has a low tolerance to opioids, or they've been through the detox phase, but now they're struggling with the cravings and the reward issue, then they might have a low tolerance if they're not actively using, versus somebody who's using heavily daily, then we would consider that to be a high tolerance. And so based on the clinical determination of tolerance, that's how we decide what dose to begin. In terms of titration or changing the dose, the initial studies back in the 1960s suggested a certain dose where patients began to stop using the illicit drug. And that drug back in the 1960s was heroin, and now it's fentanyl. So things have changed a little bit with fentanyl in terms of the dose, but in general, methadone is still very effective for both any type of illicit opioid abuse. Methadone will counteract it in terms of it's basically trading one opioid for another, because methadone is an opioid. We just feel like it is much safer because of the route of administration and the duration of action. So methadone was really developed because it had a long half-life, so the effect lasts significantly longer than the drugs of abuse. And so that's why it's so useful.
Do you see any higher level of stigma associated with either one of those three? I know you mentioned the 3 FDA-approved medications for opioid disorder being methadone, buprenorphine, and naltrexone. So my brain went to that when you're talking about having this conversation with a new patient, potential patient coming in. You're explaining, the ins and outs of an agonist, a partial, and an antagonist. Do you hear, if anything, a consistent stigmatized thing that helps them skew nay or way for a different medication?
I would say that it's probably a minority of patients who fear the stigma of being on a methadone clinic. I think that the general public has an idea of what methadone clinics are, and that's where the real misconceptions are. It's really from the broader community versus the patient who's made their life has improved vastly with methadone. Then they may be stigmatized in that way, but I think that as the epidemic of the opioids has been ever present here for more than 10 years now, that people in treatment aren't avoiding it because of that stigma. It's really just more of the perception of the community and that sort of fosters the stigma and that continues that stigma. Methadone clinics, since they are so highly regulated, and they sometimes can be viewed negatively in the community because the community may not understand that there isn't a cure for this disease. So methadone is a one treatment option that is again highly regulated by the federal government, and so those regulations make it very strict in terms of the day-to-day process at these clinics. And so I think that I don't see patients not coming to a methadone clinic because of that stigma. I think the stigma is sort of something that's been there, and it's really more of this educational component that people in the general community who don't see this disease or aren't affected directly have maybe a negative viewpoint of these clinics, because we all sort of, just a simple example in Massachusetts is the marathon, the methadone mile that we call it in Boston. And so that everybody thinks of that and says that's a negative, that seems like a negative thing to talk about. And everybody really knows what it is, but it's called the methadone mile. And so that's where I think the stigma is more historical, and I think that will change over time because, again, methadone saves lives. And therefore, I think that in general, one of the misconceptions I think that the community has is that people with this disease or this disorder are choosing to continue to do this, and it's an active choice. And the choice is part of this issue, but it's really more than that. Once you have this condition, there is no cure, and the reward associated with the opioid use makes it next to impossible to not continue to use or abuse an illicit drug.
Yeah, nail on the head, doctor. I think a lot of people don't realize. The recovery community is pretty hip, treatment community is pretty hip, but a lot of community members, right, don't realize that there's physiological changes that have taken place in the brain due to prolonged exposure to drugs, to be specific, we're talking opioids, and I think still the biggest stigma lies, a touch to your point, is in the community. We work really hard on that pre-engagement, get an individual go from actively using to engage in OTP, and then we're in the next meeting asking how they're doing. Things are going well, but I got to get off of this stuff. right? Which I feel like that's exacerbated by a level of stigma or shame, right? You know, from cats that are coming in the cut, there's just lack of understanding of how it may benefit.
Well, I think that in the last 5 years, with the changes that COVID brought to the OTP world, or the opioid treatment program, methadone clinic, has been to take away some of the negative connotations of the treatment. So. The typical methadone clinic, the patient needs to come to the clinic every single day. The medication is a controlled substance, and so until they develop or they establish some clinical stability, we're not really allowed to send them home with a bunch of medication. Sure. And so the COVID changes have made it easier to not have to come to the clinic every day. So I think that in general, the general public and the community may not understand this in the same way as somebody who works in one of these clinics. I never worked in a methadone clinic past 5 years ago, and I was similarly biased as a medical doctor. So even though I work in the world of addiction and I had to learn methadone myself, probably as I became a methadone clinic director. I think that answers me.
Yeah, pretty much. You know, I mean, I think big thing that my brain went to when that we're talking about stigmas, right, here is the discouragement, right? Individuals feel discouraged for doing it, and I was one of them. I remember that, you know. I would go in the early morning, 5:30, in line, hood on, get my dose, keep my nose to the ground, and get out, right? And I knew it was because, you know, there was a level of shame associated with that, and guilt, you know, from some of those stigmas that are out there. You're trading one substance for another, and now, knowing what I know these days, I'm like, no crap, McFly, that's the point. You know, trade something that can kill an individual for something that they cannot. You know, something you get from a legal medical professional on a daily basis. You know what you're getting, how much you're getting. My favorite part was when you're getting it, right? No more 5 minutes and I'll be there type of thing. You know, you go see the nursing and your dose is there. You know, and they can, more often than not, it was the dosing nurses that would notice when I was out of character. Right, kind of like, Jerry, you're a little bit more squirrel today, you're a little bit more clam today, like, what are you doing, you know, and try to, you know, bridge some connections to some additional supports. You know, but I think even with the talk about stigma, right, it causes nothing but harm, you know, and I hear this often, man. I can't tell you how many times we've had to get an individual back into an inpatient level of care because they try to take themselves off the medication because they're feeling discouraged, because whether it's a family member that's uneducated or a spouse that's, you know, uneducated or not privy to, you know, the ins and outs of what that looks like, and the shame wins. They start to take themselves off, symptoms present again, right, and return to use happens pretty quickly.
Right, and we're not going to convince everybody about the way that I see this disease or this disorder and the treatment of it. I think that Al-Anon and that model of trying to get family members and community members to understand what their children are going through or their significant other is going through, it's really a education of the patient, of the person who doesn't understand medication-assisted treatment. So the relapse rate for opioid use disorder is about 90%. And so if you have this condition and you choose not to be on some form of maintenance, then the likelihood is you're going to relapse. Yeah. And the supply of drugs on the streets today is potentially very deadly. I mean, it's very potent for somebody who's never been involved with those things. Even just touching fentanyl on your hand can potentially lead to an overdose. And so somebody who is being shunned away from treatment is potentially at risk for dying. And so we see a huge push now for Narcan. The state law changed in July 1st. You see 2 doses of Narcan right there. And so I think that that's a great initiative because that's a life-saving medication.
So to bring everything back, I'd just like to continue our conversation about the other different types of medications used in the treatment for opioid use disorder.
Sure.
Could you touch on a little bit more on the buprenorphine and the various different types of medications, from the sublingual to the injection?
So buprenorphine was developed in the late 1990s. It's been available for the treatment of opioid use disorder since then. I started using it at a detox facility and started learning about it. Buprenorphine is a very interesting opioid. It's the only one that I know of that's what we call a partial agonist on that receptor. And the way that I try to explain it to patients in terms of buprenorphine is that it is a big bully on a receptor that these opioids want. They're all fighting for one receptor, and buprenorphine, it likes to occupy that receptor and kind of blocks other opioids. And so we call it a partial agonist, meaning that it activates the receptor, but it also doesn't let go of the receptor. And so patients, as long as the reward center in the brain is satisfied with an opioid, then the patient doesn't crave opioids. And so what we're trying to do is maintain the receptor so that the patient isn't looking for the illicit drug. So buprenorphine or Suboxone is most commonly known. Initially was used sublingually. There have been long-term implants developed that aren't used very often. And most recently, there's long-acting injectable versions of it. And there's two different products out there. One can be given weekly by injection subcutaneously, and the other is monthly.
Okay.
And so that takes away having to take any medication sublingually, and it's very convenient for patients. They don't have to go to the pharmacy. They get their medication, and they'll be the medication will last in the system for between 4 and 6 weeks, and so during the time that they get the injection, they're not craving and they're not feeling like they need to go and use. So that's buprenorphine, and then the third medication approved for opioid use disorder is naltrexone or Vivitrol, okay. Very similar to the Narcan, and that actually goes to this receptor system that we're talking about, and it blocks the receptor for about a month. So that actually is the first long-acting injectable form of MAT. It is also approved for the use of alcohol use disorder. So if a patient has alcoholism and opioid use disorder, then I often will try to do that as a first line, the Vivitrol or naltrexone. It is the only form of MAT that you can stop without going into opioid withdrawal, because both Suboxone and methadone are opioids. So if you stop them abruptly, you potentially will have a withdrawal syndrome.
So between Sublocade, methadone, and naltrexone, what are some of the differences like between the three substances? Like what would gear someone towards one compared to the other?
You know, it's oftentimes patients have tried all three, and so it can be a sort of their own experience of being on one and maybe had a better experience with another. Methadone is what we would call sort of like the highest sort of level of care. It's the most tolerant form of care, where patients often will continue to struggle with whatever illicit drug they're doing, and we try not to stop the medication, but we try to work with the patient to try to figure out how we can change their environment of care, because I like to tell patients that no matter what form of MAT you're on, Vivitrol, methadone, or Suboxone, that if you're in front of the illicit drug, you're likely to do it. It's a very difficult thing to be able to say no, even if you're on medication to treat it. So that's where I think the community could understand a little bit different, is really it's not about a medication, it's about a medication plus the recovery, the connections in the community, the recovery housing, and the supportive recovery coaching, and so those sorts of things. But for, I mean, it's, again, there isn't a best choice. I think that out of the three medications, Suboxone and methadone are the most commonly used for opioid use disorder. They have the best efficacy. So yeah, it's really a patient choice, and I think we can achieve the desired opioid craving control with either any of those three medications, but it really just comes down to patient choice.
So I know that like medically these medications are proven to work and help people. But what about, could you touch a little bit about the importance of education and counseling and mental health, and how that also helps to strengthen the methadone, like as a combination?
Sure. We can't address their opioid use disorder or their substance use disorder without addressing their mental health. And so fortunately for me, working at High Point, we have a large contingent of psychiatry team and counseling that can offer. But we often call these conditions dual diagnosis type of conditions, where you have an opioid use disorder and you may have a major depression, or you may have bipolar disorder or a psychosis. But if you don't address the mental health side of it, you really have a more difficult time controlling the opioid use disorder and or whatever other substance use disorder they may have. So you have to really address you can't just focus on one problem. You really have to look at the patient and say, well, this is one problem, but looks like there's a couple other things that could be contributing to that problem. And so if you don't address it, it makes it really much more difficult to get the patient to buy in, to be able to help themselves stay away from the things that they're trying to stay away from.
So I'd like to take the opportunity to segue over to my friend Jerry over here. With your experience, I'd like you to touch upon how, one, the medication helped you, and then two, how you utilized the counseling, the education, the supports together to help you.
Okay, Griff. Yeah, so my medication journey was a long ride, the first 5 years of my recovery, and I think where my brain went to, Dr. G was talking about what helps people decide, right? That's where that truly individualized care comes in. I just had a full hip replacement. My goal for goals group when I was in CSS was 25 steps a day without my cane. So pain management was a big part of that deciding factor. But the big one was that I had never been able to suppress the cravings long enough to be able to follow through with the work, right? Like, I've been connected with a recovery coach before. I've been connected with a counselor and therapist, psych, all of these things. But without working on those underlying issues, my cravings would return, and I would return back to use, right? So, and how do we stop the brain from craving a substance of choice? Think it has its substance of choice, right? That's kind of how methadone works. It's a full agonist. It activates and saturates the receptors similar to heroin or fentanyl will. But just like treating any other disease on this planet, medication isn't the cure-all, right? Medication is a tool we use to suppress symptoms to make treatment smoother, whatever that may look like. You know?
I think that I'll touch upon something that sort of I think is really important, and is that there are many triggers, or what we call triggers to opioid craving. And when we talk about treatment with medications, we're targeting one receptor, and this receptor controls the pathway of that reward. But there are other pathways that will trick us into thinking that we're not on enough medication, or this medication is not working for me. And that's really, it could be severe depression, it could be something, a painful condition could make your brain take you down that road to say, well, I'm on maintenance medication, but I'm not doing well enough because it's not working for me, because I have pain, or I have depression, or I have anxiety, and yet I can't target those things with methadone because that won't work for those cravings. And so that's the importance of the counseling, and the importance of those connections is to say, we have to identify each person who has this disorder has a different set of cravings based on different environmental cues. It could be a sound, it could be a smell, it could be anything that they associated with that high. And so in order to really educate the patient, we say, listen, I can target opioid cravings with methadone or with Suboxone or with naltrexone based on one receptor, but we can't target those cravings if they're based on something other than that receptor, meaning some pain, anxiety, or worry. So I think that is really important, because without the patient understanding that there will be times when they feel like they need to use, then if my answer, if they're always going to come to me and say, well, I need more of a dose, I'll say, well, maybe we're going down the wrong path, because it's not about more, it's about the right dose with the right set of education and support.
The right connections to stuff, right? And that's kind of what some of the precedents of hardcore connections, right? Because we don't, especially on methadone, we don't talk about this when I'm doing these groups and educational, in services in the community and providers and things like that. Individuals don't crave the opioids first, right? It's an operant condition. They're craving the dopamine. They're craving that reward that you touched on, right? And now I'm used to, doing a spike or whatever we're doing that floods the opioids in with a rush of that synthetic dopamine. Right now I go to a clinic, I get my dose of methadone that has a slow onset and a long half-life, which means it doesn't come with that flood of dopamine, right? So maybe my withdrawal and my opioid cravings might be, but I'm still, where's the rest of that feel-good juice, Doc, right? And that's why we see other individuals engaging in either continued substance use, switching substances, or pursuing other process addictions.
I think that brings up another important point, is that once a patient is initiated or starts on methadone, we don't expect that use is going to stop until they reach a certain dose. And so I always also explain to patients that the first dose of methadone, you may not even feel it, and you're definitely not going to feel the full effect of it for a few days. And so I try to make sure patients understand that, because the frustration could be, well, I just got this medication, it's not working.
It's not working. Take me off, Doc.
It takes time, and so we have to make sure the patient is understanding that it will happen. It's just a matter of patience and sort of sticking to the with the program.
Yeah, and really individualizing what that program looks like for that individual. For a Gryffindor of the world, it might be going and playing Magic. It might be going A, B, C, and D. For someone else, it might be 90 meetings in 90 days. It might be, CBT. But really taking that time to dive in and what is unique to this individual. How can we make this individual's experience unique and hopefully have a different outcome, providing that additional.
Yeah, and I think that on the flip side is, once we get somebody stabilized on any form of MAT, then it's a function of either staying with it for the long term because we don't have a cure, or if the patient's goal is no medication, then we will continue that education process, continuing the counseling process, wean the medication slow to the point where the patient actually can stop. So this is not a forever medication, but we do recommend it long term.
Yeah, and I love it. I used it for about 2.5 years on the methadone clinic, before working with utilizing other evidence-based practices, then transitioned to the buprenorphine, or sublingual Suboxone. Rode that up for 3 years and say okay, I can self-administer my medication, and I can manage this, and life was pretty manageable. Then it's time to come off of these medications, transitioned over to the long-acting injectable that you mentioned, and did that for, 9 injections, under you and Anne-Marie's care over there, which thank you for that, my dude. Phenomenal, super cool to go from patient, to being colleague, man, and super grateful to have you on here to be able to hopefully disseminate some education to make it readily received, easily digestible maybe, to people that don't hear it so often, right? And if someone is doing something for their recovery, whether it's using less or getting on a methadone clinic, don't ever discourage that. I think is a big part of that. If you're not saying you got to be proud or high five everyone that I got on the clinic, but definitely don't discourage them for it. And I hear so much of that, man, which is we know is stigma driving that.
Absolutely.
Bus, so.
Even amongst the community of AA and NA, we always hear the stigma shows up at those meetings. One of the first questions you hear is, who in here is on maintenance treatment? And they say, well, okay, you're not sober.
Then leave. Yeah.
Well, wait, hold on a second. That's not the way to approach that. Even from the community of patients who are all in it together, they're even so. It can be frowned upon. Maintenance treatment can be frowned upon, and that's unfortunate.
Yeah, and if you're on maintenance, find the right fellowship. That's why I brought Mara to Plymouth. Medication Assisted Recovery Anonymous. It was established in 2019. Myself and Angel, we now have 11 meetings rocking in this state. Which is phenomenal. It's a judgment-free space. To meet individuals where they're at, regardless if you're on medication or not. Which is
right.
It's wild.
Yeah, 100% of patients will develop this disorder if they have access to opioids. So I think the other major.
Hit me with that stat one more time, Doc, please.
100% of in my opinion, if you give an opioid long enough to anyone, they will become dependent, and that's a physiological change in the way that our body works. And so, to me, and I think that the message has been out there for a while now. It's all about prevention. We can prevent our next generations from dealing with this for the most part, because it is about education. It potentially could be one wrong dose of something that was given to somebody, and you could become dependent, and then you might be stuck for the rest of your life. So, to me, prevention is the key, because once you have this disorder, we're maintaining them.
So it's a supply and demand issue. Stop focusing on the supply, eliminate the demand. we'll be in a much better spot.
That's absolutely right.
We'll get in there and talk.
And on that note, I'd like to thank you, Dr. G, for joining us again today. That's all the time that we have. Thank you, Jerry, for sharing your story. For everyone else, thank you for joining us to get some education, to try to start smashing these stigmas, and I look forward to seeing you guys next time.
See you next time.
Thank you.